Okay, well, welcome back. I know it's been a really long time. Just been drowning in residency, but decided today's the day that we get back to it. So, if you remember a long time ago, there was the first part of this, which was essentially how do we treat, diagnose, and kind of manage PLEs in the ER and the ICU. Well, this second part is really just like a quick rundown of common and less common causes to just remember. This isn't supposed to be like medicine level depth, but things just kind of remember why you're in the ER and the ICU, and then there's extra information if you want to pause and take a look at it yourself. So there's many causes of PLEs or protein losing enteropathies, as you can kind of see on the left, and we'll go through each of them. So I think the most common is probably lymphangiectasia. And so there's kind of two categories similar to the majority of diseases out there. So there's a primary, they're either born with it or it's something idiopathic. I'd say breeds that are really common for that would be Yorkies, Lundahounds, if I said that correctly, and then soft-coated Wheaten Terriers. And then secondary could be due to like lymphangitis, which is usually more so like a brachycephalic, specifically French Bulldog kind of thing. Clinical pathologic abnormalities could include lymphopenia, which makes sense as you're getting rid of or you're losing essentially your chyle and your, I guess, lymphatic flow. You're losing those lymphocytes. And so the pathophysiology is essentially the lymphatic flow is impaired. So it's either the chyle's either being retained. Um, the lymphatic flow is impaired, leading to retained chyle. So that then causes dilated lacteals, and then they eventually rupture because of the increased pressure within them. Again, these are kind of a low pressure system, so I don't imagine it takes too much to do so. Prognosis is kind of all over the place, but in my experience, at least being confined to academia, it's usually pretty good, assuming that the owners follow directions to a T. Over on the left, you'll see ultrasound findings. So it's like very common, just these kind of like mucosal, hyperechoic like striations, as you might see them called, and then endoscopy. You see all these dilated lacteals, which can be more obvious if you feed them kind of like corn oil or a smidge of a fatty meal about like 8 to 12 hours before endoscopy. And I'd say the next most common thing would be like IBD or inflammatory bowel disease, and there's four different major types. The one we commonly think about is just like the standard lymphoplasmacytic, and then categories would be like diet, steroid, and or antimicrobial responsive, with the last one being pretty uncommon. So it's presumed the pathophysiology. It's not 100% elucidated, but they think that there's just some kind of decreased tolerance to just the standard bacteria that are in the gut, dietary antigens, whether that comes from food or ingesting things out in the environment. And then the big thing to remember is with cats, this is on a continuous spectrum with small cell GI lymphoma. Typically, when you're trying to figure out is this inflammation versus lymphoma, we do look for like things like plasma cells in your FNAs or your biopsies. But in small cell GI lymphoma, you can see plasmacytosis within the tissues. The most common way to diagnose it is really a presumed. So, kind of, does the history, clinical signs exam, and response to treatment kind of fit with that? Other supportive information you can get would be like an abdominal ultrasound looking for enteritis or thickening of certain layers of the intestinal tract. The Texas A&M GI panel, so really focusing on like cobalamin and folate, but you could also include PLI and TLI for a more thorough workup, which is usually unnecessary, and then response to treatment, and then again, biopsies. You can either do endoscopic, which is really just mucosal, which is where you're going to get that diagnosis, or if you want to be fairly certain or you think there's something else going on, like infiltrative neoplasia, full thickness surgical biopsies may make more sense. Treatment, really the first thing to do is you switch them to a hydrolyzed or a novel protein diet. The second step would then be immunosuppressing. It's been shown that immunosuppression is kind of a negative prognostic indicator in itself, which again, about 66, if I'm remembering that correctly, or about two-thirds of patients usually just respond to the diet change alone. And then third step just kind of depends on, client and patient tolerance of symptoms and medications. Relapses are definitely possible. So if this is what you think your patient in ER ICU has, you need to make that 1000% clear to the owners. And that even just getting a bite of another dog's food that's not kind of that same hydrolyzed diet can kind of set them over the edge. And this is I've had many clients where this is an issue for them is being able to stick to that. Another big thing is patients that are improperly treated or not treated may exhibit cyclical episodes of GI distress. So I've had a couple cats where the owners are not giving the steroids according to the plan that we discussed. And I had one cat in my internship where it was every 8 weeks, almost to a T, where she would have very similar symptoms. So lymphoplasmacytic is the most common in dogs and cats. We're typically going to see it in middle to older age dogs and then also cats. And the majority of patients are going to go into remission, whether that be partial or complete, with again about 2/3 of those responding to diet alone. Next is the eosinophilic, which is uncommon. Big things is Rottweilers, right? Like they are predisposed to hypereosinophilic syndromes. So that's kind of the first breed that I think of. And they are at increased risk of GI ulceration, GI perfs. But before we start going down that train and giving them kind of like a less favorable prognosis than with lymphoplasmacytic, look for the common things that cause eosinophilia. Parasitism's the big one. Diet reactions or food reactions, drug reactions. Addison's can cause a peripheral eosinophilia, but I wasn't able to find anything in the literature saying that's going to cause an eosinophilia in tissue biopsies. And then certain cancers like mast cell tumors. Prognosis is fair. I guess it really depends on what other systemic issues do they have. Pretty rare now is neutrophilic, so the big one to look out for is E. coli and consider FISH testing or fluorescence in situ hybridization, which is the image you see on the right, and then raw diets. The prognosis is usually pretty poor. Granulomatous, so it's the rarest of them all, and the ones that you're going to think about would be, again, pretty uncommon, would be Mycobacterium, Yersinia, Enterocolitica, and Prototheca. Once those ones are typically found, they're pretty not great, or they require a really long extended period of time for treatment, like for Mycobacterium. And then other would be like Histoplasma capsulatum. So that in itself is probably the more common cause of granulomatous IBD that we can see. I'm unaware of any literature that says what their long-term prognosis or their GI symptoms will be after successful treatment. And then these are usually your boxers, your Frenchies. Prognosis is not fantastic. So an interesting one that I always forget about would be gluten-sensitive enteropathy. This is usually in Irish setters. They're pretty young and it's typically confined to the proximal small intestine, with it being kind of similar with biopsies with lymphoplasmacytic IBD. You can run a GI panel and you should, not always, have a normal cobalamin and a low folate. And the prognosis is usually pretty good, but finding a gluten-free diet can be cost prohibitive. Histiocytic ulcerative colitis, I've yet to have one, but this is usually severe large bowel diarrhea in brachycephalics like boxers or Frenchies. And then treatment, I don't really think is worth mentioning too much on an ER ICU basis, but the prognosis is kind of up in the air. And then immunoproliferative enteropathy or Basenji gastroenteritis. They're usually pretty young, less than 3 years of age. They can have manifestations outside the GI tract. It's typically going to arise as for like a lymphoplasmacytic enteritis, but however, they are known to progress into spontaneous intestinal perfs. You may have gastric involvement, so at that point, you may want to call it a gastroenteropathy. And then it's pretty poor long-term prognosis. Familial protein losing enteropathy and nephropathy. So this is really just a thing in soft-coated Wheaten Terriers, which is pretty bad. They're typically going to show signs of PLE first, or I guess I should say have the pathophysiology of a PLE first and then a PLN. So typically we'll see like a small bowel diarrhea before a large bowel, and females are more likely to be represented. And then lymphangitis, it's really seen more so in small breed dogs and Frenchies. It's exceedingly rare, so I'm not going to talk about it too much. And then crypt pathology is its own category of diseases. I think the thing to think about is it's sterile cystic abscesses in the intestines, which it's primarily going to be Yorkies. So kind of a big differential other than IBD and lymphangiectasia. Chronic intussusceptions. So we I commonly see this in young, like pretty young dogs, so make sure you're looking for intestinal parasites. Even if a zinc sulfate comes back as negative, you should still be deworming them. Even if you send out the test and everything other than parasites shows up, whatever that may be, still treat them because that's pretty cheap and easy to treat for. Other things could be idiopathic, which is pretty unlikely. What an intussusception is it's an invagination of one segment of the GI tract, kind of telescoping into an adjacent or juxtaposed segment. And usually what's going to happen is it's going to go how food usually goes from mouth to anus, essentially. So antegrade or aborad, and then retrograde is exceedingly uncommon. I didn't really find anything in the literature where it's going backwards. And how I describe this to owners is if you've ever taken off a tube sock and it kind of sucks in on itself, that's the easiest way for me to describe it. About 60% of these cases are going to be small intestine going into the colon. And then on the left, you see in the abdominal ultrasound, you kind of have this bullseye pattern. And then this is harder to see, but kind of looks like a telescope going in. And then endoscopy, which I've yet to see one on endoscopy, you can see this segment kind of uh, invaginating through. This is a nice review in GI foreign bodies. The big thing is if it's gastric, the majority of them are amenable to endoscopic removal. Erosions and ulcers, this can be a primary. It's typically going to be a secondary thing. So remember the difference between erosions is pretty superficial and then ulcers get pretty deep. A lot of infectious causes, you can read them on your own. I think the big ones to remember that are kind of weird is that whipworms or Trichuris vulpes and salmonella can cause a pseudo-Addisonian-like presentation, so hyponatremia, hyperkalemia. I mentioned this because I actually had someone recently go down this long Addisonian train workup, spent a lot of money, and then it turned out fecal was forgotten and it was positive for whipworms. So just stupid easy to treat for and to look for. Histoplasma, it's kind of similar to blastomyces. So the big thing is it's going to be on the East Coast and kind of like Midwestern-ish, the United States, and then 1/3 of cases are strictly indoor cats. Now, based on that information, it's not known. Do these have attics? Are they in basements? And those are kind of the questions that I ask clients rather than being like, do they have exposure to birds and bats? You're most commonly going to see large bowel diarrhea. So young cats and dogs, there may be an increased risk in pointers, Wymies, and then Brittany Spaniels. And remember, with any fungal disease, particularly blasto, coccidio, histo, they can show up anywhere. So I was taught in school the mnemonic bells, so bones, eyes, lungs, lymph nodes, and skin. Cats, I feel like the most common location that we're going to find it first would be the lungs. And then in the dogs, about 3/4 of them are in the GI tract. You can do kind of like a rectal scraping or a rectal cytology if you are unable to refer for endoscopy or it's just not in the budget. Easiest way to diagnose this, you actually get a urine sample and you submit it to the fungal lab in the US, so Mira Vista. You can do a bunch of different samples, but I typically do urine. And make sure you're doing the antigen, not the antibody. The antibody doesn't have as much use because it just tells you if there's exposure. And then they are treated with an antifungal for a long time, and then relapse is common in about 1/4 of them, regardless of how things went. And then neoplasia, I am not an oncologist. These are just more so for you guys, so you kind of have like a nice list all in one place. So lymphoma is the most common in cats. It's about 2/3 of the cases are low grade and confined to the GIT, which again, remember I said earlier, it's on a continuous spectrum with IBD, T cell over B cell. So T for terrible, B for bad. Small cells typically going to have diffuse infiltration with plasma cells in like the muscularis layer of the intestines. Remember that I said earlier, typically when we look for lymphoma, if you see plasma cells, there's a lower degree of suspicion, but I think that's why they put it on this continuous spectrum with IBD. It's pretty common. It's a better prognosis. The majority of cats will respond to like prednisolone and chlorambucil. It says below can live 4 to 12 months. I've had cats that have lived years. So then large cell lymphoma, it's more common in dogs. You may see mass-like lesions more commonly, and it's got a pretty poor prognosis. I think the longest I've seen a patient go with any form of large cell lymphoma is about 2 months. Mast cell tumors, it's the third most common of the GI tract in cats. So remember, spleen is a big place for cats, especially if they have diffuse splenomegaly, and then less so the liver, and then the GI tract. It's typically going to be in the small intestines, and then we're commonly going to see GI ulceration. Remember that mast cell degranulation leads to histamine and kinin release, which kind of can lead to those things. And then it's going to be a non-circumferential eccentric wall thickening, and the majority of these are already pretty metastatic. And then leiomyomas and leiomyosarcomas, they're the most common intestinal mesenchymal tumor, but I would say pretty uncommon. I saw my first case ever last week on soft tissue surgery. The dog was about 14 years old. It's commonly going to be in the small intestine, but this patient had it in the large intestine, and they grow pretty slowly and they are locally invasive. But apparently, metastasis is not in itself a negative prognostic indicator. And then I learned from the surgeon I was working with that because these are smooth muscle tumors, these actually peel away from the affected tissue pretty easily. And then you just suture up the defect, which is mind blowing and super cool. And then GI stromal tumors or GISTs or GISTs, those are kind of like a newer categorization of kind of these smooth muscle tumors, which again, it's not super important, but if you wanted to do IHC, you do KIT. And then GISTs, again, pretty similar to what I just said with leiomyosarcomas, but these guys are going to originate from the submucosa, from the interstitial cells of Cajal. And then it's better if it's large intestinal than small intestinal. Gastric carcinoma, so this is a big one. So Belgian shepherds, so Malinois, other types of shepherds are kind of the breed that we think about with gastric carcinomas, which is really unfortunate. If you have any shepherd, but especially older shepherds, primarily males that have hematemesis or bloody regurg or just anorexia, and you're worried about a gastric lesion, I would put gastric carcinoma pretty high up there. About 3/4 of them do have metastasis, and then surgery, because it is in the pylorus, can be pretty extensive, like a Billroth 1 or 2, so biliary rerouting. I'm not going to speak about that too much, and their prognosis is usually pretty crappy. And unfortunately, most of these are not really safely amenable to endoscopy because they're already pretty ulcerated. As you can see here, this is like a pretty big gastric wall tumor, kind of here with a bunch of ulceration. Intestinal carcinoma, so it's commonly going to be the large intestine. It's going to have like a mass effect, and about 50% of them are going to metastasize if they're found in the small intestine. It turns out females have a significantly shorter median survival time. Surgery is going to be the way to go. Chemo, the jury's kind of out. Gastronoma, one of my favorite, most elusive cancers there are. So it's extremely uncommon, but essentially gastrin, which is a hormone that increases gastric parietal cell hydrochloric acid production and then does stimulate to a lesser degree pancreatic D cells. It's exactly what it sounds like. So increased gastric acids leads to hyperacidity, regurgitation, esophagitis, GERD, ulcerations, maldigestive disorders or syndromes. Really, the best way to diagnose this, other than if it is surgically amenable with following histopathology, are resting serum gastrin levels. But the big issue is you see all these false positives. So decreased renal clearance, chronic gastritis, partial anorectomies, liver disease. The big ones would be steroids, famotidine, PPIs such as omeprazole, pantoprazole, esomeprazole, which I've had a couple suspicious cases that have like pretty severe hematemesis, melanohematochezia, but they've already been started on these things. So it's hard to say. The prognosis can be pretty guarded. And then carcinoids, they're exceedingly rare. And then here are all the systemic causes. I would love to jibber jabber about all of them, but just ones to keep in mind. Again, hypoadrenocorticism or Addison's. You're going to be looking for kind of those classic things, but do not forget about pseudoaddisonian syndrome with whipworms and salmonella. So hopefully that wasn't too fast, but kind of gave you a perspective of things that you should remember with PLE and the ER and the ICU. And hopefully another video will be coming shortly. Thanks a lot, and bye.